Pulmonary pathology. I'm your lecturer, Tymofii Shynkarenko, for this topic. Pulmonary pathology is probably the largest topic of systemic pathology, with developmental disorders, metabolic disorders, stroke disorders, inflammatory disorders, and neoplastic diseases. The last two categories are the most numerous. What we have to deal with today: normal anatomy and histology, congenital disease, atelectasis, acute pulmonary injury, infections, obstructive restrictive concepts, obstructive pulmonary disease, restrictive infiltrative pulmonary disease, vascular pulmonary diseases, neoplasms, and pleura. So I'm sure that you need anatomy and histology to understand the principles of lung pathology. So if you understand what the structures are, you can understand better what happens to them. Then lung, those are lung arteries, bronchial tree, and they form the smallest parts, alveoli on the periphery. Alveoli are shown in this picture too. So you see they have extremely thin, tiny walls. So 1 kilogram in total, 2 lobes on the right side, 3 lobes on 2 lobes on the left side, 3 lobes on the right side, of course. 10 segments, approximately 10 segments on the left and 10 segments on the right side. Bronchi, you have to know their main bronchi, then segmental bronchi, lobular bronchi, and so on. Arteries, pulmonary artery goes with bronchi. Bronchial arteries, veins, you see they are shown there with blue color. Visceral pleura on the surface of lung tissue, and the visceral one or parietal one lining their chest cavity. Nerves are present just in the pleura. So when some process doesn't involve pleural tissue, the patient doesn't feel any pain, any feelings. So oftentimes you had a cough and you couldn't complain of any pain. So that's why. Bronchi. Again, I can show you some bronchi there with no blood. Bronchioles, the smallest bronchi. Terminal bronchioles are even smaller, like this one. Alveolar ducts, so long spaces with air. Alveoli there. So a lot of them, probably billions of alveoli in any lung. Type 1 pneumocytes.
Teacher, can you please accept other students?
I can't change the course of then YouTube. Yeah, type 1 pneumocytes for respiratory function, to exchange the gases. Type 2 pneumocytes to produce surfactant. Yeah, so you know this word, right? Macrophages. Actually, pneumocytes are epithelial cells with some macrophagic abilities. However, when you inhale a lot of dust, macrophages have to absorb dust particles. Capillaries, small capillaries, the smallest capillaries there, I think. So then with a schematic picture, you see the capillary lumen, alveolar space. What is between them? Alveolocytes or pneumocytes type 2, type 1, some internal cells, and the basal membrane between them. So just one basal membrane and 2 layers of cells. Endothelial cells, pneumocytes, that's it. Yeah. So with electron microscopy, it's not that clear, but the same. One layer of cells, another one, and their basal membrane between. So the development of lungs from their forgot, yeah. So with 2 buds forming left and right lung in the future. Yeah. So you see how it works. A normal X-ray, you look at their heart shade, shade of heart, and also the vessels of lungs. So they are just vessels. I can't see anything else, just vessels. Probably bronchial tree when they are scleroside, yeah, with sclerosis, when they contain a lot of collagen. These lung fields are not completely translucent for X-rays. You can notice some small dots or some kind of so that's not opacity. That's normal lung tissue. Normal lung tissue. Then liver and stomach. You see there gases in stomach, oftentimes beneath the heart. Normal X-ray. Congenital disorders, we don't have any questions, Croc 1 for that, but you have to know the words. Agenesis, no development. No development. No genesis development. No development. Hyperplasia, hypo, low level, pleasure, growth, low level of growth. Agenesis, no lung at all. Hyperplasia, small lungs. Before of their problems during the intrauterine part of our life. Tracheal bronchial anomalies. So trachea is a esophageal fistula. So that's the additional duct between trachea and esophagus. Trachea and esophagus. Let's look at that. So that's atresia of esophagus. Then with fistula. So when you see their fistula, so when trachea and esophagus are joined to each other because of their problems in their embryonal part of life, vascular anomalies with some aneurysms of arteries or abnormal structure, abnormal location of vessels. Congenital emphysema. We'll look at emphysema a little bit later. Foregut cyst, cavities full of liquid formed from foregut. Pulmonary artery malformations, congenital pulmonary artery malformations. Poor formation or abnormal formation of pulmonary artery. Sequestration when there is no connection to airways or pulmonary arteries, but systemic. So when you see the bronchial arteries but no lung arteries, then atelectasis. Atelectasis is a rather concept than disease. So we can find this word in different conditions in different MCQs. Yeah, so don't sleep, please. Yeah. Incomplete expansion. Incomplete expansion when, for example, some tumor grow in the bronchi, the lung tissue isn't aerated with a resorption or of the air from it. Yeah, incomplete expansion here, I think, with the liquid in pleural cavity. It could be water, hydrothorax. It could be blood, hemothorax. It could be air with pneumothorax and contraction in pneumosclerosis. That's pneumosclerosis, for example. Acute pulmonary injury, the next point with pulmonary edema. So pulmonary edema, that's the situation we have gone through in hemodynamic disorders. With the congestion, with the excess of blood in the vessel. In the vessels, traffic jams, I would say, and then transmission of liquid with low level of proteins. This liquid is called transudate. Increased venous pressure. So, for example, in the settings of heart failure, left ventricular heart failure, decreased oncotic pressure in nephrotic syndrome, in liver cirrhosis, and so on, lymphatic obstruction and alveolar injury. In the alveolar injury, we call that acute respiratory distress syndrome. Morphologically, the name is diffuse alveolar damage or shock lung. Non-specific pattern of lung injury. So it could be because of chemical, biological, physical factors. So some students asked me to explain for each pointer. So infections in pneumonia, physical injury with radiation, toxic with toxins from somewhere, especially from air, chemical with drugs, DAC, disseminated intravascular coagulation, and this one is the most interesting, etc. Yeah, so the list is too long, and they have written etc. and so on. RDS again. So you see there hyaline membranes, the most specific feature of this disorder. So you see the hyaline formed on the walls of alveoli. Can these absorb their function? No. This hyaline is their block for gas exchange. It's a block. And this condition requires not just ventilation of lungs, but also oxygenation of blood. There are specific machines that could oxygenate blood of those patients. You know, amid coronavirus pandemic, they required such techniques. That's the most common complication of coronavirus pneumonia. So that's the extreme condition that led to thousands and probably millions of deaths last year.
Doctor, what is the relation between ADS and surfactant?
Look, actually, acute respiratory distress syndrome is called, in contrast to neonatal respiratory distress syndrome. Neonatal respiratory distress syndrome is based on the surfactant deficiency in neonates. But in acute respiratory distress syndrome, surfactant plays no role at all. Yeah. Acute interstitial pneumonia. Think of it as ARDS with no known etiology. We call such diseases idiopathic pathology. Next one, infections. All cases. A 38-year-old woman after hypothermia, cold weather, developed chills, high fever, cough, sharp pain in the chest because of pleural involvement on the right side. So you know that the process is right-sided when breathing. Death occurred on the fifth day. At autopsy, the lower lobe of the right lung was enlarged, dense, gray, with granular surface on the section, gray film-like deposits on the pleura. What disease did the patient have? So that's the lung full of liquid, full of exudate. So the whole lobe was involved. We call that lobar pneumonia or Kruppe's pneumonia. Kruppe's pneumonia, lobar pneumonia, or pleural pneumonia. Lobar pneumonia emphasizes the fact that this pneumonia can affect 1, 2, 3, 4, 5. Is it possible to have 6 lobes with lobar pneumonia? Don't know, guys. I don't think so, because anyone has only 5 lobes. And this condition is extremely difficult to go through because, you know, the whole lobe is not functioning. So it means the lung failure, and usually fatal sometimes. No, this time it's not that lethal as before, but anyway, someone could die because of this condition. Yeah, Kruppe's condition, pneumonia, lobar pneumonia, pleural pneumonia. Kruppe's pneumonia means the inflammation called Kruppe's. Fibrinous inflammation with easily excreted or films, yeah, so excreted filaments of fibrin, and pleural pneumonia because you see that those bacteria are just below the pleura, and they go through it and infect pleural cavity. So this condition is associated with pleuritis every time. Yeah. Stages of lobar pneumonia. Congestion, the first day with exudate in the alveoli, congestion, regularization with red blood cells in the alveoli, so hemorrhages, small hemorrhages there, gregipodization with a lot of neutrophils and fibrin formed there, and resolution. It takes weeks and months to recover. Gregipodization grossly, you see that this tissue looks like liver, especially when you apply percussion, when you need to percuss from upper parts of lungs downwards. You'll find the border of liver sound, dull sound, somewhere up than you expected. And microscopically, neutrophils and fibrin, not the best picture. Ay, ay, ay. Great presentation, yeah? So next one. So to treat such infections, we have to categorize them. We have to know the list of the most likely bacteria to cover them. So the infections are divided into community acquired in the community, in a theater, in a cinema, in a classroom, in the transport, anywhere. Yeah, Streptococcus pneumonia, Haemophilus influenza, Varicella. So those are the most common bacteria we have to cover with antibacterial drugs, antibiotics. Community-acquired atypical pneumonias, non-bacterial, influenza infections, severe acute respiratory syndrome, and coronavirus infection, yeah, SARS-2. Nosocomial pneumonia. Nosocomial means the pneumonia associated with care, medical care. Aspiration pneumonia, because of the aspiration, so because of aspiration or inhalation of solid or liquids into bronchi, aspiration. So these liquids or solid particles can block the airways and cause the proliferation of bacteria. Lung abscess, especially anaerobic bacteria. Lung abscess, it will cover that. Chronic pneumonia with those are associated with productive inflammation from the first day. Pneumonia in the immunocompromised host in either pulmonary disease in human deficiency virus infection. So pneumonia or pneumonitis. Yeah, pneumonitis is the most general term, including all the inflammatory processes in lung tissue. Pneumonia is a word used for their exudative processes in the alveoli. So when you see something in the alveoli, it would be called pneumonia. Differentiation from injuries, obstructive disease, so you have to differentiate every time, of course. Differentiation from neoplasms, it's not very difficult because most pneumonias are acute and they take just 1 month for the full resolution. Lobar pneumonia, I've shown it already, and bone pneumonia, when the foci are concentrated around bronchi. So it starts in bronchi and spread to the adjacent alveoli. Interstitial alveolar pneumonia. Interstitial in the interstitial tissue, so in the walls, alveolar within the alveolar lumen. Community, nosocomial, and etiological agents host immunity. So most bacteria, most microorganisms cannot cause, they cannot induce any disease with the normal level of our immunity. So oftentimes we need some predisposing factors to develop pneumonias to presenting symptoms. What are they? Cough and dyspnea. Two diagnostic methods. What are they? So I guess CT scan, radiological method, and probably spirography. Any organism can cause pneumonia with immunodeficiency, especially when they're immunocompromised people. Predisposing factors: loss of cough reflex. So when something goes into bronchi, we cough and return it back to their mouth, to their throat, and then we can swallow it. In the people with a neurological deficit, they aspirate solids, they aspirate liquids so commonly. Diminished mucin or ciliary function. You know, in people with cystic fibrosis or Cartagena syndrome, pneumonias are extremely common. Why? Because their bronchi don't clean their air properly. Alveolar macrophage interference. So alveolar macrophages are important for their defense from bacteria. Vascular flow impairment. So without blood, we cannot support macrophages. We cannot support any humoral immunity mechanisms. Bronchial flow impairment. So we need aeration to block the growth of bacteria. Although pneumonia is one of the most common causes of death, it usually does not occur in healthy people spontaneously. Case 2, an autopsy of a man with a malignant tumor. So you see, it had a background of the stomach, who died of cachexia, extreme loss of weight, revealed dense gray-red, irregularly shaped foci in the posterior and lower parts of the lungs, protruding above the surface of the incision or of the cut surface. Microscopically, the lumen walls of small bronchi and alveoli show exudate with many neutrophils. What disease is detected in the lungs? Of course, that was acute purulent bronchopneumonia. Could it be interstitial pneumonia? No, definitely no, because in interstitial pneumonia, alveoli are, the lumen of alveoli is clear. Acute bronchitis, no, not just bronchi, but also alveoli are involved. Low pneumonia, no, because it was not lobe, but numerous foci scattered over the lung tissue. It wasn't cirrhosis with many neutrophils, so they have shown purulent suppurative inflammation. So you see, is it A? No, it's B. It's B with multiple foci scattered over lung tissue. Community acquired, atypical, so with a typical, especially viral causative agents, nosocomial in their hospitals, aspiration in alcoholic people, chronic, they are not common, but sometimes fungi and some bacteria can cause chronic course of pneumonia. Necrotizing abscess formation, so with the tendency for to the death and then formation of abscess. Pneumonias in immunocompromised hosts. Let's go through it. Community acquired with Diplococcus pneumonia, the most common one. Diplococcus. So you have to remember it because this microorganism is known as the causative agent of lobar pneumonia. They like this question. Streptococcus, the classic lobar pneumonia, normal flora, but with some level of immunodeficiency, not always AIDS, some level because of cold weather, because of low nutrition, or some somatic diseases. they can settle down in the alveoli. Only 20% of victims have plasma blood cultures. Penicillins are often 100% curative. Yeah, so vaccines are often 100% preventive. Vaccines are distributed for all the people. In elderly, they suffer from severe lobar pneumonias. So it's important to protect our older part of society from such infections. Okay, and this one, on X-ray, you see the shade of the whole lobe, or probably two lobes, uniform, so with no any translucent areas. So that was lobar pneumonia. Grossly, you see that this lobe is gray, enlarged, covered with fibrin. Microscopically, the walls contain congested capillaries. They are thickened. In the lumen, the cells are, oh, by the way, there are siderophages with hemosiderin, red blood cells, neutrophils, and fibrin. So that's something between red hepatization and gray hepatization then. Pneumonia is the common cause of pneumonia in children. They also have the vaccine against it. So that's meningitis caused by this microorganism. So meningitis, purulent meningitis, and bronpneumonia in lungs. Bronpneumonia, microbiology. Staphylococcus aureus is the most common pneumonia following viral pneumonias. So it's like complication of viral pneumonias. The same with coronavirus infection. After it, the patients are vulnerable to other types of microorganisms. So they open the gate for bacteria. Bacteria are already in the bronchi, and they are limited with our protective mechanisms. In coronavirus infection, the mechanisms are broken, and bacteria walk through alveoli. Resistant staphylococci, of course, is not community acquired. It's the nosocomial infection acquired in the hospitals. Klebsiella pneumonia could be in lobar pneumonia. Common in alcoholics. Pseudomonas aeruginosa, Legionella. Although pneumonia is one of the most common causes of death, it usually does not occur in healthy people spontaneously. You should remember that. Then acute pneumonia, organizing pneumonia, chronic pneumonia, fibrosis versus full resolution. So in acute pneumonia, we'll see the fibrin in the alveoli, and those fibrin fibers should be resolved. Unfortunately, our macrophages are smaller, and they cannot consume the full fiber. So they are inadequate for this process. However, in neutrophils, you'll find some enzymes that can degrade fibrin to smaller parts, and then full resolution is less common, but at least partially that's possible to resolve. Another result is fibrosis, sclerosis, fibrosis of lung tissue. Typical with viruses, with mycoplasma, non-bacterial cultures are not helpful. These bacteria or viruses don't grow in their laboratories, in the clinical laboratories. Yeah. Viral pneumonias, frequently interstitial, not alveolar. So oftentimes they are in the walls of alveoli, whereas bacterial processes are in the lumen. Influenza virus, we'll talk about that in infections. SARS was their an ancestor of SARS-2, COVID-19. Yeah, so that was the shit with coronavirus. The first outbreak was in China, 202, spread chiefly in Asia. Like most often, most other non-bacterial pneumonias confirmed by PCR. You have seen that in the reports. Like most viral pneumonias, interstitium infiltrated, some giant cells often present. So it's similar to what we see in influenza, to be honest. Yeah, similar. So the damage is diffuse. So in all the parts of lungs, this virus was invading. The communal in people in hospitals, hospital-acquired, debilitation, catheters, ventilators, specific bacteria, especially resistant bacteria, aspiration, and conscious patients, especially people who drink a lot. Yeah, patients in prolonged bed rest, lack of ability to swallow, usually caused by aspiration of gastric contents. Posterior lobes are gravity dependent, most commonly involved, especially the superior segments of the lower lobes, often leads to abscesses. So that's another view when you see the pneumonia, yeah, mostly here. So in the person with multiple how to call them? They measure equipment, yeah, equipment to measure something. An autopsy of a 47-year-old man who died of heart failure revealed a pus-filled cavity measuring 4 centimeters in diameter in his left lung with a fastened irregular wall and lung tissue. It's most likely to be that was not cavernous tuberculosis because it contained pus. Pus is the feature of purulent inflammation or bacterial inflammation. So it's either chronic abscess or acute abscess. To differentiate them, you have to look at the wall. In this case, the wall was formed by lung tissue, so the answer is acute abscess then. Acute abscess. So pus-filled cavity is abscess with lung tissue, acute abscess in lungs. Lung abscesses aspiration, decomposition, ablation, so many causes. Microscopically, large area of necrosis, so full of pus. Chronic pneumonia, usually not persistences of the immunity or nosocomial bacterial infection, but can be, at least histologically, often synonymous with the four classic systemic fungal or granulomatoous pulmonary infections. If you see pulmonary granulomas, think of a chronic process. Obstruction versus restriction. We should think of obstructive or restrictive disorders in chronic lung diseases. So that's applicable for acute infections, but nobody does that. Nobody does that. Obstruction or restriction. Obstruction means the blockage of bronchi. Restriction means there are problems in expansion, in the expansion of lung tissue. Obstruction is small airway problem, and in restriction, reduced volume for somewhat reason. Obstructive pulmonary diseases, emphysema, almost always chronic bronchitis causing emphysema in years or in decades after their onset, asthma, and bronchiectasis. So let's look at them. An autopsy of a 42-year-old patient suffering from chronic diffuse bronchitis who died of pulmonary and heart failure revealed large area lungs covering the mediastinum. That's uncommon in normal conditions. Normally, lungs are both side from heart, but they cannot cover. Not collapsing, pale gray in color, so they contain a lot of air. Cut with crunch, pressing with a finger leaves a fossa on the lung surface. Mucopurulent exudate is secreted from the lumen of the bronchi. Make a diagnosis. That was emphysema. Emphysema, like hyper-aeration of lungs or hyper expanded lungs. Yeah. What's the form of emphysema? What's the forms? Chronic focal? No. It was in both lungs, sir. In all the lobes? No. Interstitial emphysema? No, that wasn't interstitial emphysema. Primary idiopathic emphysema? No, it wasn't idiopathic, I think, because we know the previous condition. We know that it was followed. It followed chronic diffuse bronchitis. Vicarious compensatory emphysema? No, because compensatory emphysema could be in someone who lost his lung. So, for example, who underwent the operation of lung removal for any reason, for trauma, for lung cancer, and so on. So the only current answer is chronic diffuse obstructive pulmonary emphysema. Chronic diffuse obstructive pulmonary emphysema, and look, chronic diffuse bronchitis is the cause of emphysema development. Large lungs covering the mediastinum, not collapsing. So all these features are specific for emphysema. COPD or end-stage lung disease. So emphysema is very common in any condition, any chronic lung disease. Center-acinar in the center of acinus, pan-acinar, paraseptal, irregular. Progressive expiratory and air trapping within. Air trapping. So the bronchi allow the air come in, but they are too narrow for going to let air go out. So they have the problem with expiration, with breathing out. Like cirrhosis through of as end stage, thought of as end stage of multiple chronic small airway obstructive pathologies. Non-specific, but oftentimes because of smoking, you know, because of smoking. Increased crepitance, bulla, blabs in lungs. Clinically are likely to produce recurrent pneumonias and progressive failure. Case 5. A patient suffering from chronic obstructive pulmonary emphysema has died of pulmonary heart failure. What changes can be detected in the heart? So that was chronic lung disease. Chronic lung disease can cause the problems in right ventricle. Right ventricle is supposed to pump blood through lungs. When the lungs are busy, when they are destroyed, when they are out of order, right ventricle has to apply more efforts, make more efforts. So that's hypertrophy of the right ventricle, or the name called, it's called cor pulmonale, hypertrophy of the right ventricle. So you see central acinar in the center of acinus, in the areas adjacent to the bronchioles, and panacinar with their large spaces, larger alveoli dilated in all the parts of alveolar tissue of their acinus, whole acinar. So this pattern, oh, you see some cavities. Oh, yeah. You see some blabs full of air, bulla. And the same is seen on X-ray. So you see the translucent area here and here, translucent areas because of air. So especially here, it's easy to notice lung tissue. Lung tissue is not that black as those blabs. The radiological features of emphysema: hyperexpansion, so they are enlarged. Flattened diaphragms, so they are lower. Bulla, so the spaces with no lung tissue. Increased lucency. Why lucency? Because of the air. Case 6. An autopsy of a patient who died of cardiopulmonary failure revealed purulent exudate in the lumen of the small bronchi and hypertrophy of the right heart. Histologically, mucosal gland hyperplasia, lymphoplasmacytic inflammatory infiltration of bronchial mucosa, prebronchial sclerosis. What is the most likely diagnosis? So we see the problem is where? In small bronchi. Mucosal gland hyperplasia, where is the small bronchi? Lymphoplasmacytic infiltration in bronchial mucosa. So the problem was in bronchi. Was it acute or chronic? Chronic. Because of sclerosis. Sclerosis takes time to develop, at least 14 days, but in grosser cases, when you see it grossly, it must be year or more aged. Small bronchi with problems. Yeah. Hypertrophy of the right heart is non-specific. It could be in emphysema, it could be in chronic bronchitis, could be in silicosis, in any disease of chronic cars. Chronic bronchitis, inhalants, pollution, cigarettes, chronic cough can often progress to emphysema. Mucus hypersecretion early, the goblet cell increase. That means goblet cell increase. Chronic bronchial inflammatory infiltrate. Asthma, similar to chronic bronchitis, but wheezing is hallmark. Bronchospasm, wheezing, strong allergic row with eosinophils, imbalance E, allergens, often starting in childhood. Almost nowhere in adulthood. Atopic or non-atopic with infection. Chronic small airway obstruction and infection. Mucus hypersecretion with plugging, lymphocytes, eosinophils, luminarwin. So the most important one is eosinophils. So when they are, we say asthma. When they are absent, it's more likely to say chronic bronchitis. So we see there hyperplasia of goblet cells there, lymphoid nodule adjacent to the bronchus. The lumen is narrowed with a little bit of hyperplasia in muscular layer. You see, also you could notice emphysema. You could notice that the alveoli are over-distended. So all four features are given there. All four features are given in this place. Case 7. An 8-year-old child with a signs of work, fingernails, cough with significant amount of mucopurulent and sputum, especially in the morning. X-ray examination reveals a sharp dilation of the bronchi. What disease are these changes indicative of? First of all, you should understand that shortness of breath, drumstick fingers, clockwork fingernails are non-specific. They just the signs of cardiopulmonary failure. So they had cardiopulmonary failure and then they repeated what exactly was revealed in that patient of mucopurulent sputum. Significant amounts. So it was not 10 meters. Probably that was 100 milliliters or 500 milliliters. It is possible to collect that much sputum in the bronchi, in the normal bronchi. No, that's not possible. They have to be dilated for that. How to call the dilation of bronchi? Bronchiectasis. Bronchiectatic disease is the answer for this case. And significant amounts of mucopurulent sputum, that's important. And dilation was given in the question, was given there. Bronchiectasis, dilatation of the bronchus associated with often necrotizing inflammation, congenital, tuberculosis, bronchial obstruction, rheumatoid arthritis, systemic leukocytomatosis, inflammatory bowel disease, and others. So to form bronchiectasis, you need two main like preconditions, yeah, preconditions. You need a high pressure because of obstruction. It's quite common in obstructive disease, high pressure and necrosis. So necrosis makes the walls softer, and obstruction makes the pressure unbelievably high. Bronchiectasis here. So these bronchi are dilated, and they could contain hundreds of milliliters of sputum. So a lot of sputum. Bronchiectasis. Restrictive disorders. Reduced compliance, reduced gas exchange. Also diffuse with high density, with low crepitance, so with no sounds from alveoli. The normal sounds are decreased. Heterogeneous etiologies, fibrosing diseases, gallmatose diseases, eosinophilic diseases, smoking-related diseases, pulmonary alveolar proteinosis with proteins occupying the alveoli. Fibrosing diseases, idiopathic pulmonary fibrosis, non-specific interstitial fibrosis, cryptogenic organizing pneumonia, collagen vascular disease. What you have to remember is the patient died of increasing pulmonary insufficiency, histological examination revealed diffuse lung damage with interstitial edema, infiltration of interstitial tissue with lymphocytes, macrophages, plasma cells, pneumofibrosis. Your diagnosis, pulmonary atelectasis? No. Atelectasis is just a kind of condition, yeah. So it's not the disease. Chronic bronchitis. Have they said something about bronchi? Not at all. Bronchopneumonia, again, nothing about bronchi, no changes in the alveoli, so no. Bronchial asthma, no eosinophils, no bronchial asthma. Fibrosing alveolitis is the correct answer for this case. Fibrosing alveolitis, idiopathic alveolar fibrosis. Fibrosing alveolitis, chronic inflammation in the alveolar walls. Idiopathic disease with fibrosis, so we don't know any cause. So they ruled out leukocytomatosis, scleroderma, so they have ruled everything out, and they have to give the name for the condition. They say idiopathic pulmonary fibrosis. So you see fibrosis there, connective tissue. So sclerosis, growth of tissue like in my sclera, white, dense tissue. Fibrosis, advanced sclerosis, I would say, and cirrhosis, the last stage with deformation of lung appearance. Non-specific interstitial pneumonia. Non-specific interstitial pneumonia with, so let's skip them. I don't have enough time. Collagen vascular disease. An autopsy of a 59-year-old man who died of chronic heart failure. Again, we see that heart suffers a lot, when their patients have chronic lung conditions. The lungs were large, dense, sparsely airy, with multiple diffusely arranged whitish nodules, 2-3 millimeters in diameter on section. Microscopically, the nodules are represented by this concentrically arranged collagen fibers. What's the disease in question? This question was dedicated to nodular form of silicosis. How to prove that? Fibrosing alveolitis is diffuse. It doesn't form any nodules. Miliary pulmonary tuberculosis could be revealed in the person with granulomas. They haven't mentioned any granulomas. They have mentioned just the outcome of glomatose or sterile inflammation. Minor focal, so that's I would say bronchopneumonia. Yeah, bronchopneumonia. No, that's not bronchopneumonia. Whitish nodule. Why? Tumor metastasis to the lungs. Again, nothing about cellular atypia. Cellular atypia. Again, multiple diffusely arranged whitish nodules, concentrically arranged collagen fibers. Silicosis belongs to the group of disease called pneumoconiosis. They are occupational, so they depend on their profession. Them oftentimes they refer to coal miners. Lung, dust or chemicals or organic materials. Coal in anticosis, silica dust in silicosis, asbestosis with asbestos and other minor forms. Coal dust can cause anticosis, bagasosis, asbestos body, ferruginous body in asbestosis, and the nodules they have described in the question with concentrically located fibers of collagen. That's the result of dermatose inflammation. That was granuloma before, but now it's a sclerotic nodule. Dermatose inflammation with sarcoidosis, hypersensitivity diseases of dermatose. Most of them are dermatose. So even silicosis is dermatose condition. However, they don't describe those granulomas. In most cases, patients are examined when silicosis causes those fibrotic disease with unknown etiology, with unknown causes. Immune genetic factors play some role. Young adult black woman. So asteroid bodies is a giant cell seen in sarcoidosis. Microscopically, it's similar to tuberculosis, to be honest, but with no necrosis, or a little fibrinoid necrosis, probably sometimes. Smoking related. So, a lot. And pulmonary alveolar proteinosis with a lot of protein. So you see that's transudate, and this one is protein-rich material. Much protein. Vascular pulmonary diseases, just one case, I think. An autopsy revealed a large wedge-shaped focus of crimson red dense tissue in the upper lobe of the right lung. Histological examination revealed necrosis of the alveolar walls, the alveolar lumen densely filled with erythrocytes. What process has developed in the lungs? So what was that? Hemorrhagic pulmonary infarction. You could notice a large wedge-shaped focus. So that was infarction. That was the focus, the shape of which is explained with the architecture of lung tissue. Wedge-shaped focus. You see the cells died because of the blockage of blood flow with hemorrhagic infiltration of lung tissue. Pulmonary embolism, pulmonary hypertension, hemorrhagic syndromes. Pulmonary embolism are usually secondary to debilitated states with embolization or following surgery, usually deep leg and deep pelvic veins, not superficial veins, follows virtuous stride, that is flow problems, internal disruption, hypocoagulability, usually do not infarct, usually ventilate. So when they do infarct, the infarct is hemorrhagic. Why hemorrhagic? Because one part of circulatory system is blocked, pulmonary artery branches, but another one, bronchial arteries, is still functioning. It can provide exercise to the dead tissue, decreased acute chest pain, mismatch, ventilation, circulatory mismatch. Chest CT, angiogram, short-term heparin. So you see that ventilation is quite good, but perfusion is impaired on the left side. I think that's a problem. On the saddle embolism, that's a great case to review, to brush up their cardiovascular problems with human disorders. Pulmonary hypertension, COPTER, CIPD, so congenital heart disease, increased left atrial pressure, recurrent PM. So normal pulmonary arteriole, and this one with thickened wall and narrow lumen, pulmonary hypertension. Hemorrhagic syndromes, good posture syndrome, antibodies to the alpha-3 chains of collagen 4, glomerular base membrane deposits 2. So two problems together in lungs with the bleeding to the alveoli, and in kidneys with nephritic syndrome. Idiopathic pulmonary hemosiderosis, to be differentiated from chronic congenital heart failure. Vaginal granulomatosis, congestive heart failure. So congestive heart failure, chronic congestive heart failure with Prussian blue reaction with hemostyrene, emphasizing stressing hemostyrene. Idiopathic pulmonary hemosiderosis. So you see that the alveoli are full of siderine, hemosiderine. The last case, a patient has high fever, dyspnea, and pain in the right side of the chest. A pleural puncture revealed 700 meters of yellow-green viscous fluid. What closure process has developed in the pleural cavity? So we see that it contains yellow-green viscous fluid, pus. That was pus. So we have to find purulent inflammation in pleura. Pleural empyema is a great choice. Pleural empyema. So wait it up, thank you, and give up smoking. That's high time you gave up smoking.